Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
For this week's show, I have a special treat. My friend and friend of the show, Sarah Wells, was kind enough to give me a call when she was on the road with the ENA Cultural exchange program and checked in from both the Netherlands and then again from Sweden. So what I have for you today is that conversation and Sarah sharing a little bit of her information about what she was seeing while she was there. You're going to love this episode. Enjoyed this episode this week with Sarah Wells, the new thing nurse, checking in from the road. Sarah, what are you doing this week?
Guys, I am so excited. I'm talking to you from Amsterdam in the Netherlands, where I'm on the Emergency Nurses Association 2019 Cultural Exchange Program, which is this amazing program that they started. Last year was one of the first trips in recent history. They had programs like this in the past, but this is a new start to this. And where what we get to do is that a group of Emergency Nurses Association members from all over the United States are coming to Europe, to two countries. The Netherlands, we're going to be in Amsterdam and some of the outlying cities here, and then also in Stockholm, Sweden, to shadow and shadow in the emergency departments and learn about the healthcare system of the really interesting healthcare systems in these two countries, and learn how they're different, how they're similar, what does emergency nursing look like in these two countries, and what practices can we bring back to the United States to help enhance our practice, and what can we teach to the nurses over here to enhance their practice. And it's just going to be an amazing week.
That sounds like that's going to be an amazing trip. Holy cow.
Yes, I'm so excited. So last year, I was actually lucky enough to go on the 2018 Cultural Exchange Program, and that program was to Norway and to Poland. And so I got to learn and see all about those healthcare systems. And so I'm very excited to be back in Europe to take advantage of this opportunity again.
How exciting. So what brought you there last time when you were there?
So I've come to Amsterdam in the past. So I love to travel, and I travel pretty actively in my personal time, professional time. Anytime I can get on a plane and go somewhere, I try to go. And I was here about a year and a half ago, and the Emergency Nurses Association, as you know, it is my favorite professional organization for nurses. And through it, I know people all over the country and all over the world. And so we actually had a member at the time who is based out of the Netherlands. He lives in a town called Leiden, which is outside Amsterdam. And I just reached out to him on Facebook and said, hey, you don't know me, but we're both in the Emergency Nurses Association, and I'm going to be in Amsterdam for a week on vacation with my husband. And I was wondering if, one, you might have any recommendations for us, and then two, would it be possible to come see her where you work? Could we chat and have coffee? So that's Joop Brewer, who is now on our board. He's he's our very first international board member. And he was so kind. He said, sure, I don't know you, but you can come to my medical center, come to my hospital, and I will show you around. I didn't know what to expect. I got on the train, went to Leiden, and Joop gave me this amazing opportunity where he toured me all through the Leiden University Medical Center, which is this giant research, teaching, and trauma center in Leiden, which is just a smaller town outside of Amsterdam, easily reached by train. And he showed me the emergency department, the ICU, and just kind of gave me a quick overview of what the healthcare system in the Netherlands is. And I was so excited to do that, and it was such an awesome opportunity to hear and listen about their healthcare system. So now here I am about almost 2 years later, and I'm here with the ENA officially on this program, and we have a whole day of education and shadowing planned for this Thursday, and I'm so excited to come back and see it in an even more expansive way and get to see it with my ENA friends and family, right? So I get to see them with people from all over the country, and we're going to get to ask questions, learn, see things, and really see something from a different perspective from a different country.
How exciting. When you went there before, was there anything that surprised you or shocked you about their emergency department, or something that you thought was vastly different from the EDs you were used to?
So generally in Europe is my experience, especially here in the Netherlands. They don't have a very big focus on opiate management of pain. They don't use a lot of opioids in the hospital system at all, and so that's a huge practice difference from our practice in the emergency departments in the U.S. And then also it was really interesting how they operate their healthcare system in general. So here in the Netherlands and in most countries in the European Union, they have a nationalized healthcare system. And what that means is that through taxes paid by the residents of the country, everyone has a state-funded health insurance. And everyone is assigned a primary care doctor, and everyone has access to very affordable healthcare, affordable prescription management, and you are almost you're expected to go, and people do go and take advantage of this. So in general, people in the emergency department, you're not having people come in because they can't get into their doctor's office, because they can't get to the dentist, because they can't get to these things. Everyone has this access to preventative care, and they take advantage of it. So people in general seemed much more relaxed. They had much lower volumes of people in the emergency department. They also had much less of what I would call abuse of the EMS system. The EMS system was really responding to emergencies. People culturally know when to call their 911 equivalent system. And ambulances can actually not transport people if they aren't deemed an emergency at that time.
Wow.
And so they have a lot less crowding, right? They have a lot less crowding in their emergency department. And another thing that I was really shocked by, and I had this experience also in Poland and Norway last year, was the discussion about workplace violence. So in the US, as you know, as any nurse in America knows, we are subjected to so much verbal abuse, physical abuse in the workplace. Threats, bullying by patients, family members, by visitors. In Europe, that just doesn't seem to be a thing. Like, it doesn't exist. There are occasions where people are belligerent and maybe intoxicated, altered, and things like that, but there is not this experience of abuse and workplace violence here in Europe. And so when I talk about, well, how do you handle your patients when they become violent, I always get really strange looks. And they don't have the security issues like we do over in the US. And so I don't know if that's from a culture of more patients. I don't know if it's a culture of patients having more access to care, and so less frustration, less wait times and things like that. I don't know if it's I don't know what that difference is, but it is, I think, greatly changes the experience of the nursing staff here in the healthcare system in the Netherlands and in Europe.
I would imagine. Holy cow! The differences. Those are pretty big differences.
Very stark. Yes, very
Holy
stark.
Cow. That's kind of cool.
Yeah. It's like all the positives, but not as many of the negatives. I mean, I think it's still stressful and hard, and there are challenges they're having. Challenges I did hear about that are similar to us. So they're facing a nursing shortage kind of all over Europe. They have an aging population like we do, so they have too many patients and not enough nurses coming in. Nurses aren't, I think, paid very as highly as in some areas of the U.S., but everyone makes a pretty good living wage, and they don't have issues around healthcare because everyone has healthcare insurance, and things like that. So there are things that they are challenged with, right? How to handle mental health patients, I think, is a pretty pervasive problem throughout. They have a different system and approach to it here, but they also are having, mental health patients and how to manage them. And then also just managing the growing patient population in general. So there are a lot of similarities also, but the differences are very, very evident.
I did at your Fill the Cup meetup, I did a quick interview with Kim, who is a nurse practitioner.
Yes.
He's Norway's only nurse practitioner.
I mean, how cool is that? You got to interview the only nurse practitioner in the country.
Only nurse practitioner in the
cool.
country. So I hope you get a chance to see him. But it was fascinating to hear how that they're just starting to explore that idea of the advanced practice providers. So
yes,
it's fascinating to see that the differences between the two systems, and I can't wait to hear how your experience goes this time.
Yes, I'm thrilled. And in some ways, it's the emergency specialty here isn't as developed as in the US. So in some countries, like in Norway, they do not currently have emergency doctors, emergency medicine physicians in the emergency room. It's like in the old days in the US, it's just whatever specialty needs to pick up that patient comes down and sees the patient. So if it's a medical patient, it's internal medicine. If it's a surgical patient, surgery comes down, but there's no emergency medicine provider. And last year, while I was in Norway, we saw a presentation by emergency medicine physician who's trying to develop that specialty for physicians in Norway so that emergency will be the main person in the emergency departments in Norway. Similarly, the nurse practitioner role is brand new in Norway, and Kim's the first one. So here in a lot of the emergency departments in EU, at least the ones I've seen in Poland, Norway is not part of the EU, but also in Scandinavia and in the Netherlands, they also do not have emergency medicine physicians. And the nurse practitioner PA role is not developed in most places that I've been. So it's kind of interesting. When I was in Norway, the speaker that we saw talking about the development of the emergency medical specialty for physicians said that they're kind of taking most of their notes and templates and experiences from the US when we developed that specialty, 30-ish years ago.
Nice.
And so they're like, it's great because we already have an example of how it should work, how it can work. But they are integrating it into a very different medical system because Norway also has a nationalized medical system, state-funded medical system. Yeah. So it is a very different experience in that way. But I think it's really cool how the different countries can learn from each other and how we might be able to tailor and adapt our systems to better serve our patients by learning from the experiences and systems from other countries abroad.
How exciting. What an exciting opportunity that you have to go there and see this system. How cool.
Yeah, and I really encourage anyone who's interested in this. Right now, this is the second year we've done it in this kind of new chapter of the cultural exchange program. But this year at EN 19, we did a presentation about our experience. A group of us did a panel from the trip last year, and Jeff Solheim, who is one of the major key players in getting all of this organized and set up for last year, said that ENA is exploring and continuing these programs in the future. And some of the future locations they're exploring are places like Australia, Italy, Ireland, Iceland. So look for 2020 because this trip might be back and the possible locations are sounding incredible.
That'd be very cool. That's definitely a bucket list thing for me to go do that.
Yeah, and I would love to see you recording all over Europe and around the world. That would be so fun. The Art of Emergency Nursing International. Yeah.
When I was at EN 19, I got an opportunity to meet one of the nurses from Australia, who was one of our representatives from the international delegation. And I got plans to interview her on the podcast coming up soon. Hopefully we can get her on and hear a little bit about how what medicine's like there. And of course,
I love it. I'm so excited to hear it.
And of course, I've already interviewed Joop. He was fantastic. I'll put a link to that episode in the show notes for this episode. But he did an incredible job of telling us a little bit about his system. And it was just really cool to see the differences.
And I love that he's now on our board. So we now have that international perspective. ENA is really pushing to grow internationally and extend their relationships with other countries abroad. And I just think it's a great platform for us to learn, grow, and collaborate with emergency nurses all over the world.
Absolutely. Absolutely. Now, will you call me again after Stockholm and let me know how that went as well?
100%. Absolutely, 100%. I mean, that's all new to me, so I'm very excited to see that. I'll have all the things to tell you and to review. It'll be so exciting.
I'm super excited. Now, how do you get from the Netherlands to Norway to Sweden?
To Sweden, it's a plane ride, and I'm not exactly sure how far. I think it's a couple hours potentially. Everything looks real close on that map when you look at it, but Europe's big, so it's far, sometimes real far. But we take a plane and we're leaving very early on Friday morning. I think our checkout at the hotel is 4 a.m. So I'm very excited about that. Sunrise.
It'll feel like the evening to you, because that's what evening in California time where you're usually based.
Yes. And if anyone's ever interested in travel tips for all of this, let me tell you, there are strategies to making 9-hour time differences work for you. So we can do that at a separate time. But yes, it'll be a whole adventure. Hopefully I'm somewhat adjusted by Friday. But yes, so we leave nice and early. We take the plane over. The lovely thing about this trip is you get a couple of days free in each of these cities to explore and experience on your own or with friends in the group. And then we get these days in the hospital, and it's just so exciting. It's such a great way to travel and explore the world.
That's super exciting. I hope you take lots of pictures. I'll be looking at your Facebook post too.
I will follow along. It'll be all over the internet. You'll get tired of it probably.
I can't wait to see it and live vicariously through your experience. So
please do. And whoever wants to follow along, reach out. Or have questions, please let me know. I'll be answering stuff on my Instagram and Facebook. And as long as I'm awake when you're awake, we can chat.
That's awesome.
All right. Well, thank you so much for having me back, Kevin. And I can't wait to talk to you again soon from Sweden.
Thank you so much. We'll talk again from Sweden. We'll talk soon.
All right.
Okay. Bye. Did you have a great time?
Yeah, no, it was super awesome. Like whenever I get back from a big trip like that, it's like always a couple of days of like,
I bet you're wiped out.
Am I? Yeah, and so it's hard to like appreciate all the greatness of it. So now I'm like 4 days back, and so it's getting clear how awesome it was, because for the last couple of days I've just been hurting because I've been so tired. My coworker yesterday was like, "You have the jet lag dosis," and I was like, "Yes, I do."
Yeah.
But it was great. So this year, and it's interesting to compare the 2 years now, because now we've done 2 of them. So this year was really fun. It was so last year we had 2 groups split up into like reverse trips, and which overlaps in the middle. This year we only had 1 group, so we had a little bit more easier time like getting to know everybody on the trip. There was like 30, it was between 30 and 40 participants.
Wow.
So I think like 35 or 36, somewhere in there, plus or minus. Yeah, it was a really great group. People from, I think there was at least 7 states. I'm not sure how many. I'd have to count it up. But all over the country, both coasts, everything. And we had just really great access the 2 days we were in the hospital. So one day we were in Leiden University Medical Center, which is Joop's facility in the Netherlands, and we had just a great tour. He put on the nicest reception for us, like just the sweetest little touches. Like they had little cakes that said ENA with the logo on them. I mean, it was just so cute. And we had a great day there. And then we went to Stockholm, and Stockholm was really lovely. And then we had awesome hosts at the Karolinska Institute University Hospitals, I think is the correct name in English, who were showing us around. And they were, their nurse leadership group that were showing us around were like PhD level academic researcher, like such smarty brains going on, many times published, like very cool people, and super engaged in like their focus is like patient safety, patient care excellence, but also nurse kind of support. And so they've adopted a nurse clinical ladder and they're adopting kind of the magnet system of shared governance, which is really cool, like a version of it. And they're researching ratios for different departments, especially the emergency department, because they don't have set ratios everywhere. They have them in some places, but they're like trying to figure out like what that means and how that could be applied to throughout the department right now. And so that was really cool to talk to them about. It was just really fun. It was like a great interaction, exchange of experiences and knowledge. So it was great. And then we had a lot of free time to like go travel and stuff. And so it was a really great trip. We had a really good time.
That's awesome. One of these days I got to go do one of those trips.
Yeah. And I think from what I've heard through the grapevine, like they're definitely invested in them. ENA is of continuing them. So I think there will be many more trips hopefully to come. I don't know that for sure, but it sounds like they're really invested in like building those relationships with their international community. And so I think these trips will continue in the future. So I think there'll be lots more opportunity for you to go, and it'll be really great and exciting.
I certainly hope so. I think it'd be
Yeah.
a lot of fun. So
Yeah, it'll be really cool. It'll be
yeah.
good. So, okay, what do you want to do? How do you want to do this bit?
So we can. So I think. Tell me about. So you told me about the Netherlands. We talked about that last time.
Yes. Okay. So let's talk
So
about
let's
Sweden.
talk a little bit about Sweden.
I love it. Okay, so I just got back from this amazing trip that we talked about previously, the ENA Cultural Exchange Program, the 2019 trip, which took me to the Netherlands and Sweden. And I was there with over 30 other emergency department nurses from across the United States. And we got to explore the healthcare system and nursing system and hospital systems and emergency departments in both the Netherlands and Sweden. And last time we talked about my trip, my experiences in the Netherlands at Leiden University Medical Center. We had a wonderful experience there this year. And we're going to talk more today about my experiences in Stockholm, Sweden. So Stockholm is a beautiful, big city that's built on all these different islands. So it's really cool when you're going from neighborhood to neighborhood, you're like almost island hopping throughout the city, which is really sweet.
Oh, wow.
Yeah, it's really cool. A lot of water. It was very chilly when we were there. So it was like probably in the 30s and 40s, a little rainy, but beautiful. Just like so much waterfront, lots of boats, got to take a boat tour, all these things. It's the home of ABBA. So we got to go explore the ABBA Museum. So if you love
God.
Mamma
I've seen
Mia,
that.
I was, Heaven, you laugh, but we had a phenomenal time. And a lot of Viking history and all this great stuff and amazing food. I had the Swedish meatballs a la IKEA, but like on the plus version. It was just great. So while we were there, we got to go to two campuses of a hospital system called the Karolinska Institute University Hospitals, I think is how they are translated in English. And we were hosted by some phenomenally educated, innovative, incredible nurse leaders there that helped show us around and teach us. They did first we set up a little in-service. So they did like some lecture about the healthcare system in general in Sweden, what that looks like and what nursing is in Sweden, kind of what that looks like, the education and stuff. And then they told us about the emergency medicine departments at Karolinska Institute in those two hospitals. These hospitals were incredible. So the Karolinska hospital system is like the busiest university system in all of Europe. They had these crazy statistics that I'm trying to pull up now about how many patients they see. And okay, so Karolinska is one of the Europe's largest university hospitals. They saw 1.35 million patient visits per year.
That's in how many hospitals?
We saw two. I think there's only two. It's 900.
Wow.
It's almost 900 beds between the two
Holy
campuses.
cow.
1.35 million. So like we're talking super busy. 2,000 researchers are on staff, and they have 3,300 scientific papers a year in collaboration with some other associations. So this is a big system, seeing a lot of patients, obviously over 1 million patient visits per year. And they're also producing a lot of research studies and papers and kind of new medical treatment programs. So it's really amazing. And so there are two campuses. We saw two of the campuses and their emergency medicine departments. The really cool thing about Sweden, so some background about the medical system there, it's very similar to a lot of the countries in Europe, including the Netherlands. It has a universal healthcare system. So it's a tax-funded universal system where everybody has health insurance and everybody has access to primary care. And all the hospitals are public except for a very small minority amount. So they're government regulated. There's a lot of standardization. So if you go to one hospital, it's going to be very, 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 very similar care as the next one because they're regulated by like one organization that is backed by the government. And so your experiences will be very similar, just with some differences depending on kind of the facility, if they're like a research facility or not, a trauma center or whatnot. All their care is almost free. They have a very low deductible system. So people have access to a primary care doctor. They go regularly. Generally, there's not these problems with follow-up that we're experiencing. So if we see a patient in the emergency department, they may be there because in the US, because they don't have health insurance. And so we are always, I feel like most ER nurses are struggling to help them fill their prescriptions and get their follow-up coordinated. And in Sweden, that's not an issue because everyone has healthcare, right?
Nice.
Right. It's awesome. But conversely, you pay a lot of taxes in Sweden. I don't know what those rates are, but they said they were very high compared to the US system. And also salaries are often lower. So we were asking what nurses made in the Karolinska hospital system. And they said new grads start around 30,000 equivalent American dollars a year. And depending on your experience, education level, and all that, that could go up to the mid to high 50,000s a year. But your health insurance is it's like very, very low pay, but you're paying a lot in taxes, obviously. And then also nursing school is free in Sweden.
Wow, that's kind of cool.
All college is free in Sweden. So you're not looking at that big nursing school debt. Also cool things going on with the nursing education. So at the Karolinska University Hospital System, they have a clinical ladder that they've modeled after the magnet system here in the US, which is really cool. And it's incentivized with both pay and I think some other benefits to increase your education level. So you're encouraged to go back and get a master's equivalent or a PhD equivalent over time. So nurses start out with like a bachelor's equivalent program. I think it's a 3-year program, education program. And then you go start working. The master's program is a year, is my understanding. And the Karolinska Hospital, at least, will pay completely for that for whatever cost there is associated with that program. The program itself is, my understanding, is free, but if there's any other fees around it, Karolinska will pay for it. And then they will actually let you go down to like half-time with full pay so that you can complete your master's program.
Wow,
so,
that's amazing.
I mean, it's not just like supporting you by paying for it, but they're also freeing up your time to do so. I think there is a max out, like they don't let everyone do it at the same time, but they do give that opportunity to their staff. And then they go up to a PhD level degree program for nurses in Sweden. And so the nurses that were showing us around were PhD level, and they have done a lot of research and published internationally. And so there's a lot of, at this hospital system at least, a big focus on nursing research, nurse-driven research and that kind of thing. So we got to explore two campuses of the Karolinska system. And it was really interesting. The two emergency medicine departments are quite different. So at the larger in the city campus, they have chosen in the past couple years to close their emergency department, is how they described it to us. And it's the only one in all of Sweden. So this is like a very unique situation. So this campus is the level 1 trauma center. And it's a facility that caters a lot to oncology patients and specialized research kind of care for those patients. And so the idea was that they would close their ED, which means that they don't take walk-in patients. They only take level 1 trauma patients, obviously. Any unstable patient by ambulance will come to them. So that's your respiratory distress, arrests, cardiac arrests, anyone who isn't safe to transfer to another facility. But anyone who wanted to self-refer, like I show up to the ER front door registration, unless you're referred by your doctor and you're in their system already, so like their oncology patients have an acute issue, they may be referred by their doctor. Anyone who wants to just show up and be seen is referred to other facilities. So they have a very low census in that way.
Interesting. I think you've said that the Netherlands is very similar, that the ER is not your first stop. You go to your GP.
Yes. Usually culturally, that's just part of the system. And also, interestingly, In Sweden, at both the campuses we saw, they had this really awesome registration system. So you came into the front door, there's a waiting room, looks like any waiting room we have here in the States. They have registration there, but they have this little machine, and it's like a self-check-in machine with a screen and a push button. So you go in, you say, hi, I want to be seen. And then when you say you want to be seen and you pick, like, I think adult or pediatric, and you're like, I'm an adult, it gives you like an array of options that you're allowed to be seen in the emergency department for.
Interesting.
And if you are there for like a low acuity complaint that your GP or an urgent care could see you for, that is not an option. And so they actually refer all patients with low acuity issues that do not need to be seen at an emergency department and refer them across the street to the urgent care. So they've said 40% of people who come in to try to self-refer, not at the closed ER, but the other ER we saw, 40% who come to the front door get referred out. So they decompress a lot of the patients they see and are able to get the right patients to the right resources.
It's amazing. It's amazing.
Right? Yeah. And they're like, we're not turning them away. We're just rerouting them to the appropriate resources that they need. And really close, like right across the street. So at this closed ER, they had a very low census and like high staffing, right? Because they are the level 1 trauma center. So they had the trauma team services. They had a pediatric line. They had oncology support people because they see a lot of oncology specialized patient populations. It was really beautiful facility. Really new was this inner city closed ER facility. And just very beautiful. 2% of the budget of each unit in their hospital system has to be dedicated to art. So there's like all this art and decoration everywhere, and it's just very aesthetically pleasing. Like you don't feel like you're in a hospital. You feel like you're more like in like a college system or something. Like
interesting.
Yeah, just really pleasant, comforting kind of environment. And then the emergency department. So the emergency department looked like any other emergency department. You had your code rooms, trauma rooms, your regular exam rooms. At the closed ED, it wasn't very busy that day, so there wasn't a lot of patients. But they said that's pretty normal for them since they've closed it. But again, this is the only one in the country that's kind of like that. But in the emergency medicine branch of services that they see, the emergency department is not the only piece of that. So they have the emergency department, which is very traditional. It looks like what we would imagine emergency department, but also within that emergency medical service line, they have several kind of clinical decision units. So these are like observational units that for where patients would go. So they've being seen in the emergency department. We don't have their inpatient bed yet. We're going to move them to a different department for about 24, 48 hours while we're figuring out where they next need to go. And so that is under the branch of the emergency medicine service line. And so we got to see those short stay units also. One of them was called I think an acute care short stay, and then there's an immediate care short stay. So acute care short stay is probably like anything medical surgical, like if you had, I don't know, like something where you needed an operation, but maybe they're not set up for you yet, and it's not like an emergent, you would go there waiting for all that to be set up, and then you would get transferred up to your inpatient bed. The intermediate care, and those are like non-telemetry patients were basically what they saw, your straightforward kind of med surg kind of stuff. Then the immediate care observational unit, they took all the tele patients. They could take BiPAP, pretty much everything that wasn't on a ventilator is what they took. And in these units, depending on the acuity of the patient, so in the straightforward acute care, like observational unit, the acute stay, they had a ratio of 6 patients to 1 nurse, a CNA, and like an internist resident. And so they would take care of those patients. And then the intermediate care, they said it was 4 to 1 nurses to patient to nurse, unless they were a little bit more higher acuity kind of thing, then they would go down. And they also had the same team of a nurse assistant, and a resident of some kind, because it is a teaching facility. Nice. And so with these observational units, they were able to decompress their the emergency department a lot easier. So they said their targeted length of stay for the emergency department patients are 9 hours or less. And they said, that is the average, not always the reality. But they said they do a pretty good job of getting them upstairs because they are the closed ER, right? So they don't have this really high volume of patients coming in.
Yeah.
Conversely, we went to the other campus, which was south of the city, a slightly older building, but a massive, huge facility. Like when you walk into it, it looks like an IKEA building, big, boxy, like going on and on and on. And it was an open ER, so a traditional ER, which is the case for like every other ER in all of Sweden. And this is where, any patient can self-refer. And it was, and they saw all the patients. However, again, they have that rule and system where if you come in and you have a low acuity complaint, you will be referred over to the urgent care or your GP, and not seen in the ER. So the patient population they're seeing are generally a little sicker, right? So think of your daily census, if you took all the primary care complaint patients out of it, those are the patients that they're seeing. Yes, these are the patients that they're seeing. So these are the abdominal pain workups, your like chest pains, your shortness of breath, all that kind of stuff. Orthopedic fractures and all those sort of things. And they also at that facility had a couple of observational units. So they had an intermediate care, and then they had a surgical care unit that was more surgical. And then they had another unit, I can't remember what it was. And similar situation there. So the ER, they want the ER patients out of there by 9 hours, and then they move them up to these observational units. And all of this is under the branch of emergency medicine there.
Wow.
Now with the nurse-patient ratios in the ER, they don't have a set one. And they said at the open ER, it was sometimes lots of patients per nurse because they're sicker patients. And so right now, a focus of some of the nurse leadership is trying to figure out if there's a way to adopt nurse-patient ratios. And so they're looking at America for part of that, in California specifically, kind of are surrounding that practice and how that might look for them. And also interestingly, their clinical ladder is based off the magnet system, which is also an American system. So there's a lot of American influence in their nursing world. And it was just a beautiful departments. They had, it looks, if you walk in, it looks very similar. Like all the equipment's very similar. The layout's very similar of what you would see. But then you kind of go behind the scenes. So one of the things that really overwhelmed us was, I think I can speak for the group, is that the size of their break rooms for their staff were huge. And they had fresh coffee grinders and these beautiful coffee machines and like fresh fruit and vegetables for the staff, and lots of light and lots of windows. And they said part of that, it's government regulations about they have to provide so much space for staff to rest and to eat and that kind of thing. Because they thought it was really odd. We were so in awe of all of this. And some of the members of our group were nursing leaders in America. And they were like, how do you get funding for all this? And they're like, we don't have to ask for anything. This is what we're supposed to do. And that was really amazing. It was just really cool and kind of funny. And then some of the other things we talked to them about was, so what are the challenges facing nursing in Sweden? So we heard some similar themes that we had heard in the Netherlands, and also similar challenges to those in the US. So they have an aging patient population in Sweden, like most of the world, with the baby boomer population. And they have they're facing a nursing shortage for a variety of reasons, but also because they have this large amount of patients that are aging and they're facing and taking care of in the future. They also have burnout issues. And so the Karolinska Hospital system is trying to figure out ways to help prevent burnout and keep their nurses and improve their nursing retention. And that has gone with, they had a recent pay increase for their nurses to kind of make it more of a living wage to keep up the cost of living in Sweden, which is quite high. They are looking at alternative scheduling. So they've decreased hours sometimes for staff down to 30 hours for full time, and they kind of play around with their schedule. An interesting thing about their schedules is they do not have set day or night shifts. So they just work whatever shifts they want, kind of. They have I was told they have a self-scheduling system where they get a wish schedule, which they self-schedule themselves, which then gets turned in. And then whoever the master scheduler is, they kind of match it up. And then there's a time where you can adjust, but no one's days or nights or mids. You just work the shifts you want to work.
Oh.
And then you have some sort of requirement of a minimum night requirement that I can't remember what it is.
I'm not sure how I would feel about that. Going back and forth from nights to days is hard. That's interesting.
But yeah, so that was kind of interesting and different for just with me. And generally they were very interested about the things that are challenges facing us, because I think they see that we have a lot of things in common. Some things that they don't have in common is they don't have as big of an issue with workplace violence, which was the same response we got to in Netherlands. They said it's definitely there. People are frustrated sometimes and they do have issues with violence, but it's not to the level that we have in the US. And then the opioid crisis is not as great in Stockholm either. It sounded like with their pain management techniques, they don't use as much PO opioid management to send people home with, and they don't use it as much in the hospital. But it's not like it doesn't exist there. They definitely have the opioid issue, but it's just not as great. They have a lot more issues, it sounds like, with alcoholism and alcohol abuse, which was different. And their mental health issues, mental health care patients also have a different system. So their mental health care is much more accessible, it sounds like, than in the US. And they have a lot more options for outpatient care, but they do wind up having a lot of mental health patients, they said, presenting to the ER, usually when they have more medical complaints, like if they're intoxicated or something like that. So it was really interesting just to kind of share those experiences and see what they're doing and what they're doing and what we're doing and how we can like learn from each other. And it was really just really fun to hear that so much of what we're doing in the US is driving what they're doing there, but they're adapting it to their system, and their system is so different from ours.
That's really interesting.
It was really good. We had a really great time.
How cool.
Yeah.
What an amazing opportunity to go and see a completely different healthcare system.
Yes. And I think when people in the US often think of different countries, they get scared of what the differences are, right? And like, if I got sick or hurt, what would it look like if I went to the hospital? But I think it's very comforting to see it's so similar in so many ways, and a nurse is a nurse is a nurse anywhere, even if the scrubs are different or if the language is different. So much of it is so similar, even when there's like these big system-wide changes. The nursing role is fundamentally the same.
That's awesome to hear.
Yeah, it was really cool. I really liked it. And I really encourage anyone, if you're ever traveling in general, if you see a hospital and you go in there and you're like, hi, I'm an ER nurse, could you show me around? It's amazing what that'll get you. And they may be able to give you some information or a tour or something. And I think it can be just this really amazing experience to really see and make you appreciate the profession of nursing, because it's just so global. Like there are nurses everywhere doing nursing care, and you have that in common with people all over the world.
Absolutely. They, I know I found when I was doing some traveling speaking, every now and then, if I see in a hospital, I'd be like, hey, let me just go in and say hello and see if there's anybody, first I get on Facebook and be like, hey, is anyone I know work around here, anywhere near here? And a lot of times I'd find somebody who knew somebody. But the times that I didn't, I just called and said, hey, I'm an ER nurse here in town. I'd just love to see your ED. And they're so open to it.
Yes. It's so cool. And I think remembering that when you're a part of an organization like Emergency Nurses Association or American Association of Critical Care Nurses, AACN, or any of those kind of big overarching organizations, or even just having social media, like I feel like I've gotten to connect with so many people online through nurses groups and forums.
Right.
I think just putting it out there, if you're interested in those kind of experiences, you will find that your community is absolutely there to welcome you with open arms all over the world, all over the country, all over the world. And it can be such a enriching experience for your own personal perspective and experience as a nurse, as your practice. I think to really experience those things in other places, it makes you really appreciate what you have, and also can help you see with the potential for growth and change in yourself and in your unit.
Absolutely. You're absolutely right. I think that's what an incredible opportunity. So,
Yeah, and I'm really excited to be able to share it with your listeners. I'm hoping anybody out there, if you have any questions, please feel free to reach out at any time. I'm always really excited to help people learn about traveling and all the benefits of traveling. And I love sharing my passion with others. So if you have questions, just please reach out. I'm happy to answer them.
well, I really appreciate you taking the time to tell us about your travels, and holy cow, what a great experience. And
Yeah.
let us live vicariously through you.
Absolutely. And this, so ENA does plan, I think, in the future to continue these trips. So if you're an ENA member, be on the lookout. Usually they start promoting these trips, I think around April or May, usually on the website and via email, the different emails they send out. And I usually am promoting them too. So if you follow New Thing Nurse at New Thing Nurse, NEWTHING NURSE on Instagram or Facebook, I usually let people know about when they're out, the applications are. And if you're not an ENA member, you can also join us on these trips. All you have to do is join ENA. That's the only requirement, is an ENA membership to go. So if you are not an emergency nurse, don't sweat. You can come. New grads are welcome. Nursing students are welcome. Last year we had a nurse who had just passed his NCLEX the week before we left.
Wow.
We've had retired nurses join us. We've had moms and daughter nurses come. We've had, this year we had a CRNA who is an ICU background, not even ER, but worked with a lot of ER patients. So it was super interesting going. So anybody who wants to go, these are great opportunities to learn and get engaged with the emergency nursing community globally, but also with ENA members. I've met some amazing ENA members I would never have met otherwise from all across the US, because there's no way to get to know someone like traveling for 10 days, like jumping from
Wow.
hotel to hotel. So it's a great opportunity to kind of explore your own practice, no matter what level you are, and no matter if you've ever gone to an ENA meeting before.
That's awesome.
Yeah.
Very cool.
Yeah.
Well, Sarah, I can't thank you enough for sharing your experience. Again, thank you. Thank you for sharing this with our audience. They're going to be really excited to hear it.
Well, super happy to do it. And thanks for having me on, Kevin. I can't wait for next time.
Awesome. We'll be talking to you again soon, I'm sure.
All right. Thank you.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.